Our first topic for today are the superficial fungal infections, also called superficial mycosis. They are called superficial fungal infections because the fungi that cause these infections only invade the epidermis and sometimes don't even go past the stratum corneum. Fungal infections that fall within this category include the dermatophytosis, Candidiasis, and Tinea versicolor. Let's start with dermatophytosis. We will be discussing 4 common forms of dermatophytosis, namely Tinea Capitis, Tiniacorporis, Tinyukurus, and Tinipedis. It is useful for us to remember the names of these dermatophytosis because just with their names, we will already know the location of these fungal infections. For example, Tinea Capitis is dermatophytosis of the scalp. Tinyukurus is dermatophytosis found anywhere on the body, except on the groins or other intertriginous areas, which is Tinyukurus, and on the feet, which is called Tinipedis. Let's start with Tinea Capitis. This is a fungal infection that occurs mainly in children, and it manifests itself as a solitary enlarging patch on the scalp that appears bald but isn't truly bald, and this is due to the hairs within the patch that become brittle and break off. They may present as one of 2 types, namely the non-inflammatory type or the inflammatory type. The non-inflammatory type of Tinea Capitis usually presents as these solitary scaly patches on the scalp. Most cases are caused by Trichophyton tonsurans and Microsporum auduini. In these lesions, there are no signs of inflammation, and so they tend to heal without scarring. The characteristic lesion of non-inflammatory Tinea Capitis presents as a solitary, bald-like patch with seborrheic-like scaling and broken off hairs within due to the invasion of the fungi into the hair shafts, which makes them break off. There is a special type of non-inflammatory Tinea Capitis known as black dot ringworm. It is so called because of the presence of these black dots within the scaly patch on the scalp. These black dots occur because the fungi produce chains of large spores that are located within the hair shafts and make them fatter. This type of Tinea Capitis is caused by Trichophyton tonsurans and Trichophyton violation. Inflammatory Tinea Capitis, on the other hand, has a very different clinical appearance. It is caused by dermatophytes of the Microsporum canis complex, which are fungi that are residents of the skin of dogs and cats and other animals. And because they are zoophilic in nature, they are very foreign to our own skin, to our own scalp. And thus, when they do invade or infect our scalp, the lesions become highly inflammatory. The typical lesion of inflammatory Tinea Capitis is called carrion cell C. It is a deep, tender, boggy, solitary plaque that exudes a lot of pus. And As you can see, it is wet and oozing and very crusty. And because of all of this intense inflammation within the lesion, these lesions lead to permanent scarring and alopecia when they heal. A special type of inflammatory Tinea Capitis is the favus. The favus appears like this, and it is caused by the fungus Trichophyton schonleini, which is a fungus that emits sulfur. And since we know that sulfur, when it precipitates, is yellow in color, that is why the favus is covered by these thick, concave yellow crusts called scutulae, and leads it to have a very distinct appearance. Since it's an inflammatory type of Tinea Capitis, these lesions heal with atrophic scarring. Now, the Wood's light is a very useful tool in diagnosing Tinea Capitis. However, not all forms of Tinea Capitis will be positive for the Wood's light. Only those that are called ectothrix types are considered fluorescent positive. In an ectothrix type of Tinea Capitis infection, the fungi tend to wrap themselves around the external or exterior part of the hair shaft. Thus, they are very accessible to the Wood's light. And when a Wood's light is used for its examination, it causes this yellow-green fluorescence on the scalp. Ectothrix type or fluorescent positive types of Tinea Capitis can be detected by Wood's light examination, and usually the types of fungi that are considered fluorescent positive are those of the Microsporum canis complex. For these types of infections, the Wood's light is very useful. However, for other types of fungal infections of the scalp, such as the endothrix type, the Wood's light examination is not very helpful. Here, the fungi, instead of wrapping themselves around the hair shaft, tend to invade the hair shaft internally. And so they cannot be detected by Wood's light examination, and so they are termed fluorescent negative. Examples of fungi that fall under this category are Trichophyton tonsurans and Trichophyton violacum. Now, not all scaly, bald, or bald-like patches on the scalp are automatically termed Tinea Capitis. There are other lesions that present in the same manner. An example is Alopecia areata. Alopecia areata is a condition in the scalp where the affected patches that appear are truly bald, and the skin that we see is not scaly, but rather is smooth and shiny without signs of inflammation or scaling. Alopecia areata is an autoimmune type of a disorder that is self-limiting, and the patient can have a regrowth of hair in these bald patches. Trichotillomania is a tic. It's a compulsion of the patient to pull at their own hair, leading to truly bald patches that look like alopecia areata but are more diffuse, with the presence within them of hairs in different lengths or stages of growth, which correlate to the different times in which the patient pulls out strands of their own hair. The skin in this lesion is smooth and shiny, again without inflammation or scaling. Seborrheic dermatitis lesions can also be differentiated from Tinea Capitis in that the patches here are erythematous, and the scaling that we see although is also scant, is loose and greasy and yellowish, and there is no sign of hair loss in these lesions. Psoriasis lesions can be differentiated from Tinea Capitis lesions as well, because the plaques here are well demarcated and very erythematous, and the scaling here is very thick and silvery white in color, and there is again no hair loss. Now let's go to Tiniacorporis, or what is commonly called ringworm. A lesion of Tiniacorporis is described as one or few circular, sharply circumscribed, slightly erythematous, dry, scaly patches on the skin. The lesion tends to have an irregular, elevated, advancing border and clearing at the center. Even if a patient has multiple lesions of Tinea corporis, they tend to be localized into one area of the body or of the skin that might have come into contact with fungal spores. Sites of predilection for this disease, or the areas of the skin where we will most likely see the infection, include the neck, the trunk, the upper extremity, and the lower extremity, areas of the skin where fungal spores can attach by contact. Now we go to Tinyukurus, or what is commonly known as jock itch or hadhad. Tinyukurus occurs most frequently in men. It is more prevalent in the summer months or when we perspire a lot, so in our country it's prevalent all year round. The lesion tends to begin in the upper inner thigh and then extends peripherally outward. And as this disease progresses, a formerly unilateral lesion now becomes bilateral, affecting the other groin as well. And later on, even spreading to the perineum and the intergluteal area and the buttocks, leading to the formation of a huge, gigantic map-like patch in the area of the genitocrural perineal area. Now, contact dermatitis is a differential for Tinyukurus that might be a little hard to truly differentiate from it, because contact dermatitis also presents as erythema and scaling in those same areas if it just so happens that a person happens to be allergic to something that comes into contact with that part of the skin. So how do you differentiate Tinyukurus from contact dermatitis in the genitocrural perineal area? This is how. In Tinyukurus, the penile shaft and scrotum are rarely involved, whereas in contact dermatitis, the entirety of the skin in the genitocrural area would be involved. Erythrasma is another differential diagnosis for Tinyukurus. It presents as this reddish to reddish-brown scaly patch, again in the groin area. However, this condition is caused by a bacteria called Corynebacterium minutissimum, and it can be differentiated from Tinyukurus because under the Wood's light, Corynebacterium minutissimum will emit a coral red fluorescence. Now let's go to Tinea Pedis. Tinea Pedis, also known as alipunga or athlete's foot, usually starts at the interdigital webs, particularly between the 4th and the 5th digit. And depending on the type of fungus that invades the skin of the feet, the lesions can start as either dry scales, as seen in the picture up top, or as painful pruritic vesicles, as seen in the picture down below. Non-inflammatory Tinea Pedis is the type that starts as scaling in between the toes. It's caused by Trichophyton rubrum. It involves the skin of the feet with a dull erythema and a silvery scaling. And this is how it will progress. In an extensive Trichophyton rubrum infection, you will see bilateral involvement of the entire soles of the feet going up to the sides, giving it a moccasin appearance, as well as the involvement of the palmar aspect of one hand, what we call the 2 feet, 1 hand syndrome. Note that the lesions are very dry and scaly and non-inflammatory. In the inflammatory form of Tinea Pedis, it starts out as pruritic vesicles in the interdigital webs, and this is usually caused by Trichophyton mentagrophytes. From these vesicles in between the interdigital webs, they spread to the plantar arc and sides of the feet, and later on, vesicles enlarge to form large, extensive, burning, itching bullae that may involve the soles of both feet. Now we go to Candidiasis, wherein we will discuss Candidal intertrigo and find out how we can differentiate it from the other fungal infection of the intertriginous area, Tiniacorporis. Candidal intertrigo is a pruritic or painful intertriginous eruption that is caused by the yeast Candida albicans. Candida albicans is an opportunistic type of infection. But in this case, Candidal intertrigo, the warmth, moisture, and maceration of the skin in the intertriginous areas promote the growth of this Candida. Candidal intertrigo can occur in the groin. It can occur in the perineal area. It can occur in the inframammary area, and it can occur in the axilla as well. But whichever intertriginous area is affected by Candidal intertrigo, there are features that we will commonly see, namely a pink to red moist central patch, such as you see here, and at the periphery of that pink to red moist central patch, you will see a fringe of macerated epidermis known as the collarette scale, as you can see here. And beyond that collaretive scale, there will also be the appearance of satellite papules and pustules all around the main moist central patch, as you can see here. So whether it be inframammary, perineal, in the groin, or in the axilla, these are the features that you will see in any lesion of Candidal intertrigo. Now we go on to Tinea versicolor. Tinea versicolor is caused by the fungus Malassezia furfur. Tinea versicolor can present as pink, hypopigmented, hyperpigmented, or even trichrome variants, hence the name Tinea versicolor. From these multicolor macules on the skin. These grow and heap up and coalesce to form larger patches on the skin, as you can see here. Tinea versicolor lesions tend to be seen in areas of the skin that perspire a lot, such as the sternum, the back, the abdomen, the groin, the axilla, and the neck. When we diagnose a patient with tinea versicolor, we also have to determine if the patient has active or inactive lesions, because it is only the active lesion that we should actually treat. How do we know if a tinea versicolor lesion is still active or if it is already inactive? Well, the secret is in the scale. Active lesions of tinea versicolor tend to have this very fine scaling on its surface. And sometimes we can see it as these faint white scaling on the surface of a very slightly elevated lesion that the patient symptomatically will say becomes red or itchy when they perspire. As opposed to inactive lesions of tinea versicolor, which are not elevated and do not become erythematous and are not scaly, but rather present themselves as flat, hypopigmented macules and patches. This hypopigmentation of these lesions is due to the lack of melanosome transfer that happens while the Malassezia furfur fungus is on top of the skin. So much so that even when the lesions are cured and there's no longer any fungi, the lesions remain hypopigmented. But this is a very temporary situation. No treatment is needed. All the patient needs to do is expose themselves to the sun, and just by the resumption of the normal melanosome transfer of pigment to the keratinocytes, these areas will repigment in time. How do we diagnose superficial fungal infections? Well, the quickest way to do this is with the use of the KOH mount. And the findings on KOH mount will differ depending on the type of fungus that is invading the patient's skin. The positive finding for a KOH mount in dermatophytosis is the presence of many long strands of hyphae in the specimen. For Candida albicans, what we will see is the presence of pseudohyphae and oval budding yeast cells such as this. For Malassezia furfur, which causes tinea versicolor, what we will see is the presence of these short, thick hyphae and multiple round spores, giving the slide what we call a spaghetti and meatballs appearance. Treatment for superficial fungal infections relies on two main groups of medicines, namely the allylamines and the triazoles. For infections such as Tiniacorporis, Tinyukurus, Tinipedis, topical treatments with topical allylamines and topical triazoles do play a role in successful treatment and management. Oral allylamines and imidazoles are reserved for more widespread Tiniacorporis and Tinipedis, especially in immunocompromised patients. However, you will note that for Tinea Capitis, topical treatment has no role, and we need to give oral antifungals for this particular indication. The reason being that in Tinea Capitis, the fungi invade the hair shaft. And since the hair shaft goes all the way down into the hair follicle, which is located in the dermis, then topical treatments are not enough to eradicate this infection. For the treatment of candidiasis, triazoles seem to be preferred over the allylamines. And unless the patient is immunocompromised or the lesions are quite widespread, topical treatments seem to be adequate in the treatment of Candidal intertrigo. For Tinea versicolor, the same holds true. Topical treatments seem to be adequate enough in the treatment of Tinea versicolor. In fact, short-term exposure to ketoconazole shampoo for short durations of time are enough to treat Malassezia furfur. However, if a patient has very widespread lesions or very recurrent lesions or is otherwise immunocompromised, then that's the only time when we shift to oral treatment for Tinea versicolor. In summary, we have discussed today the superficial fungal infections, namely the dermatophytosis Tinea Capitis, Tiniacorporis, Tinyukurus, and Tinipedis, the candidiasis called Candidal intertrigo, and Tinea versicolor. We have learned aspects of its diagnosis and management in the hope that when you encounter these diseases, one day that you will be able to differentiate one from the other.